Hello.
Allô?
Hey, can you hear me?
Vous me recevez?
ine wala iwo dago inimisa yes be ari ko honno man honno wera rambe honno e wernete wala ko honno be sita ko place a heewi mi wawi yaade ka nder sare mi amuno mi jogi do ko do ari nyawnduro pour l'islam yagale mi naba.
Dr. Bodian, can you hear me?
Yeah, I can hear you very well.
Okay. Hi, Gina. How are you? Hi, Meg.
I'm good, how are you?
I'm doing great. We're very sorry. We had a previous seminar and we just went over the time a
Yeah,
little.
it took longer than expected. Sorry.
Very, very sorry about that.
Hi. Me and Petey are both here. Can you
Yeah,
teammates?
Hey, guys. Thank you for coming.
Thank you for
Yeah.
having this.
All right, we'll get started in a few minutes.
Hello? Do you hear me?
Yeah, we can hear you very well, Mariam.
Okay, I'm so sorry. One of my audio interview was going on on my laptop and I was like, "Who's doing an interview?"
Well, it happens.
Yeah, sorry about that.
Yeah, we're glad to have you.
Yeah, I'm happy to be here too. How are you guys?
Yeah, we're doing good.
Great. Yeah. Okay, so are we waiting for some other people or?
Yeah, just a second. I think Ali will just give us Alin.
Yes, Dr. Bodian.
Shall we, or should we just wait a few minutes?
Maybe just 1 or 2 minutes, and then perhaps we can get started.
Okay.
Sounds good?
Yeah, works.
Okay. Okay, Dr. Bodian, can we get started?
Yes, Ali, we can get started.
Okay, all right. Welcome everyone to series 11 of the Fulbright virtual enrichment seminar, in which we have today Gina, who will be presenting on reproductive health in sub-Saharan Africa, and she will take us through the challenges, the rights, and transformative pathways. The format is very simple. So Gina will present for a couple minutes, anywhere from perhaps 10 to 15 minutes. And we'll have Dr. Mariam Jallo, who will intervene to give feedback and also give her perspective on the subject. And also Dr. Mamadou Bodian, who will follow up with the discussion in the Q&A session. So today, for our guest speaker, we have Dr. Mariam Jallo. Welcome, and thank you for being among us today. It's a great pleasure and honor to have you. Dr. Mariam Jallo is a medical sociologist and research associate at the Medical Research Council Unit, the Gambia, at the London School of Hygiene and Tropical Medicine. She currently leads a multidisciplinary project examining cross-border healthcare between Senegal and the Gambia, an intersection of health systems policy and mobility that demonstrates her deep commitment to improving health system in West Africa. Georgina Adelsi is a Fulbright U.S. student research trainee conducting reproductive health research among teenagers in Sierra Leone. She holds a Master's of Public Health in Maternal and Child Health from the University of North Carolina at Chapel Hill, and a Master's of Arts in English and Comparative Literature with a focus on literature, culture, and medicine. And we have Dr. Mamadou Bodian, who will be our moderator today. Dr. Mamadou Bodian is a researcher at the Social Studies Lab of the Institut Fondamental d'Afrique Noire, IFAN, at Cheikh Anta Diop University of Dakar. He serves as a coordinator of Fulbright Fellows in West Africa at the West Africa Research Center in Dakar, and he earned his PhD from the University of Florida and is a founding member of the Sahel Research Group, SRG. And of course, if you want more details on our speakers today, please refer to the terms of reference for further information. So without any further ado, I think Dr. Bodian, we can let, I don't know if you want to say a few words, but otherwise, I think we can let Gina start with the presentation, if that's okay.
Thank you so much, Alina. I think this is a great introduction. So we're going to leave the floor to Gina, and then are you going to make a presentation?
Yeah, I have just a couple slides to share.
Okay, it sounds good. Okay, you can go ahead, please.
Okay.
Thank you, Dr. Bodian.
Great.
Yeah. Okay. Oh. Okay. Can everyone see the presentation?
Perfect.
Okay. Hi, everyone. My name is Gina, and today I'll be talking about reproductive health in Sierra Leone. So my work has consisted of conducting a mixed method study, which is comprised of two parts. So we are focusing on teenagers that are currently in school in 5 communities, 4 of which are in the capital of Freetown, and then there's another community in the rural area, northern province of Sierra Leone. So the criteria for this study is you have to be between the ages of 13 to 19 years old, currently in school, and identify as a girl or a boy, and anybody outside of that criteria is not eligible for the study. So my team and I, we have started off with a pre-interview survey, and what that looks like is we have pictures of 10 different types of contraceptives in which we show the students. So this is before we conduct any interviews or talk to them. So we have the pictures, we lay them out, and they mark on the survey which ones they've seen before, which one they've heard of before. And the surveys are slightly different for boys and girls because there is a section on menstruation in the pre-interview survey, just seeing if girls understand what menstruation is, how long it lasts, if they understand what ovulation is. So the ovulation question actually is answered by boys and girls, but menstruation is girls only. So after they do the survey, then we move into the semi-structured interview to better understand their experiences. So the whole process takes about 45 to 60 minutes. Currently, 194 students have completed the interviews and surveys. Our target was 200, but we did fall short in the rural community, having 19-year-old students participate. So one of the communities I work in is the Crew Bay community. So Crew Bay, there is a lot of stigma associated with this community, as there's a lot that goes on there. I didn't know this, when I first moved there. I was happy to tell everyone I worked at Crew Bay, anybody who asked me like where I worked, but I noticed that, some faces that I got, there was like a negative stigma about the community. And so I guess learning more, visiting the community, talking to the locals, and just understanding more about the community. I guess, there's a lot that people don't know about like what really goes on there, but it just is stigmatized as like a bad community. There's a lot of things that go on there. We did interview students at this school. I think we interviewed students at 2 schools here. So some information about the community. Its rent is about $5 a month. It's one of the biggest informal housing settlements in Freetown. It's very overcrowded. There's a lack of proper sanitation facilities. At one point, the government wanted to kind of condemn the community, but the residents weren't willing to leave. So that has been like a tussle back and forth. They finally were able to create a field, but that did, cause the displacement of many individuals. This community is highly affected with the Kush epidemic that also has been prevalent in other neighboring countries such as Liberia and Guinea, next to Sierra Leone. Some of the occupations of this community also are sex work and informal sector jobs such as traders. Then this is the Kamakwi community in the north. So this is just a picture of me. We were showing the pictures of different types of contraceptives. And Kamakwi is a rural town. There are many teenage pregnancies there, starting from the age of 13. There are contraceptive options available. So there's the Chuk and Captain Band, which is the Chuk is the Depo-Provera, that's their local name for it, and then the Captain Band is the implant, Nexplanon. The occupations of this community are farmers and bike riders. Many residents want to move to the capital, but there is a lack of means to move. So some of the findings from the data that I've seen so far is, over 60% of respondents say that they have been in an abusive relationship. So part of the survey, we also ask about healthy relationships, if they understand what that means, or if they have any ideas of what a healthy relationship is. And many of the respondents did say that they have been in an abusive relationship, whether that be verbal, physical, or emotional. The IUD, the female condom, and the withdrawal method, many respondents said that they haven't seen or heard of those options before. The ones that were highly answered were the Nexplanon, and then the Depo-Provera, and then the male condom. Those are the top 3 that I've seen that, majority of them know about. Many of the interviews actually determined that students are willing to learn about reproductive health. They have a lot of questions, but they don't have the resources at their school. So a lot of them stated they want to know more about reproductive health. They want to know about how to care for themselves. And they discuss some of the curriculum in which they're taught at school. And it's basically brushed over like, you shouldn't have sex because you're going to get sick and that kind of thing. It's very surface level. And the students really showed a very great interest in wanting to know more about reproductive health, learning more about sex, menstruation, and how to protect themselves. Some of the students also reported they know which contraceptive option works for them. So some say that the implant is better than the Depo-Provera for different reasons. There is a disparity in the contraceptive knowledge between men and women. The boys do have lower knowledge of contraceptive options as compared to the women. And then financial and social barriers are the biggest reason for delaying contraceptive use. And social barriers in this context is defined as feeling embarrassed to go to the pharmacy because you're worried that someone will tell your mom, or apprehensive of going to the hospital because the nurse knows your mom or goes to your church. And then financial barriers. One question we did ask on the survey was, what do you think that Sierra Leone could do to prevent teenage pregnancy? And majority of the students did say that they do believe that they want more contraceptive options. So in the rural communities, they stated there was a group that actually came to the schools and were giving them the Depo-Provera shot or the implant. So they said they really liked that because sometimes transportation is an issue or the clinic is too far for them to be able to go. So they mentioned that they would really appreciate having more, outreach of birth control in their communities. And so another thing I wanted to mention about Crew Bay is that, so Crew Bay is, the community is primarily made up of like iron sheets and different types of materials. So another, I guess, facet of the community is that a lot of people who come from the rural areas, if they're unable to sustain themselves in Freetown and, the greater part of the city, they actually move to Crew Bay. So Crew Bay is also known as a place where there's like more freedom. So you'll see a lot of young girls living there, and you talk to them and they say, oh, I moved here from this rural community, but life in the other part of Freetown, so this is why I stay here. And many of the girls do report that, having sex like with their boyfriend or their partner, a lot of them did say that they felt like they were just talked into it. They felt like they had to be convinced, which brings other questions of, autonomy and if they really wanted to have sex with the person or not. Another thing I saw in Crew Bay specifically was the age gap relationship. So there was a lot of 15-year-olds who had 32-year-old partners. So there was a lot of age gaps. And some of these 15-year-olds already have like 2-year-old children, with the same partner. So they did state that those that wanted to share did share that if they are in an abusive relationship, let's say with a man that is older than them, they do state that their family actually has minimal involvement because maybe the partner is providing for the family. So the family actually sides with the man if, they believe the girl is doing something wrong to deserve any type of abuse. So that was something really interesting that I learned, that instead of, the family coming to the aid of their relative, they actually go to the other side, depending on how much financial support the man is giving the family. And yeah, I guess that's, about it. I know I don't have too much time, and, I want to leave any time for any questions about what I've shared.
Thank you. Thank you so much. Thank you, Gina, for this insightful presentation on adolescent reproductive health in Sierra Leone. And I am a mixed method advocate, and I really like, the fact of mixing data, but also having stories to cast light on the depth of vulnerability among teenagers, but also their openness to learn, if the right structures are in place. 3 takeaways for me. It's the first one is the kind of structural marginalizations that deepens health inequalities, but also knowledge gap and misinformation that are widespread. And the last one, which I think is very important, is the urgent need for gender sensitive, but also context-based intervention. Thank you so much for this presentation. So I'm going to hand it over to Mariam, who is also an expert of the topic, and then we can, after her presentation, of course, at least her insight, we can open the door to conversation, questions, and contributions. Mariam, the floor is yours.
Yeah, thank you so much, Mamadou, for giving me the floor and for this opportunity to take part to this conversation. Thank you, Gina, for your very insightful presentation. So Sierra Leone, I did not really know the data about Sierra Leone, so it's really a pleasure to learn more about that context. So yeah, so thank you about that for that. So yeah, and I also really enjoy your methodology. I really enjoy methodology in general. It has a qualitative, and I enjoy mixed method. And I have a question about that one. So you said that you had pre-survey interview, and then you did the in-depth interview. So how was the timeline? Did you do both of them at the same day, or have you first came and do the pre-survey and then came back do the like I just wanna know how did you organize that part? So that's my first question. Yeah.
Yes, so we first of all, got the stakeholders involved. So the nonprofit I'm working with, they have their connections with these communities. So they, let them know that I was there and what I was going to be doing. And then I went in and met the teachers who were helping us facilitate this. So the pre-interview survey, for those people who were under the age of 18, we explained the survey to them and then gave them the consent form that their parent needed to sign. So the first day of every, I guess, interview at each community was always the adults, the 18 and 19-year-olds that were able to complete everything. So we did the pre-interview survey for about 15 minutes. Individually, they were by themselves. There was nobody in the room. It was just them and the interviewer if they had any questions on how to maybe read certain words if they didn't understand, but everything was directed by them. And then after that, they completed the survey, then they went into the semi-structured interview. The only difference was in the rural community where I think I showed the picture where we were all in the classroom was due to time constraints of us being there. So we actually conducted that as a group, but we simulated testing conditions. We told them it was a test and that kind of thing.
That's great. So thank you for the responses. So yeah, so when I read the TOR term of reference of this conversation today, I was thinking that we will talk about reproductive health in a very wide way, but I have seen now that we are talking about adolescents. So I'm trying to like readjust my notes. Yeah. So yeah.
Not necessarily. I think you can just provide your take on
Okay.
on the topic, not necessarily on teenagers, right?
Okay.
That's
Okay.
yeah.
Okay, that's great because I did my PhD on unmet need on family planning and in the south of Senegal, and some of my point here are from my thesis and some others from some other work I did with exemplar project on maternal and neonatal health. Because when we talk about reproductive health, I understand maternal mortality, abortion, contraception, and everything around STIs and also adolescent health, something like that. So when we talk about sub-Saharan Africa, we can see that here we have the highest rate of maternal mortality, at least on 2020. And in terms of unmet need, we can see also that many women want to delay or avoid pregnancy, but they lack access to modern contraceptive. At least it's how we define unmet need in the politics, in all the document protocols we have. But in my thesis, I made a critique on this definition of unmet need, because what I have seen when I was in the field in the south of Senegal is that people can have access to a contraceptive method and use it indeed and not be satisfied. They can be unsatisfied because there's some side effect or some other issue around that one. They can have methods can have side effect, and also what I have seen in the field in Seju is that you can go to have an implant. They give you the implant, and then when you come back to remove the implant, the provider, the health worker, is not skilled to remove that. So it's an unsatisfaction. So that was the major contribution of my thesis, and I just wanted to highlight that one. And sub-Saharan Africa is a very problematic area. In terms of abortion, also the legal and social barriers lead to high rate of unsafe procedure, while serious health consequences contributing 5 to 17% of maternal death annually. in the world. So it's something really huge. So in terms of challenge, again, we have STIs also, which is the main concern here in Sub-Saharan Africa, the gender-based violence. We have the intimate partner violence. And I have seen you have mentioned something around gender-based violence also. I forgot which one it was. But we also have the MGF, also, which is something used in West Africa. The prevalence is about in girl age from 0 to 14 years was 22%. And we also have child marriage. We, in terms of adolescent sexual and reproductive health, it's also remain a major issue here. With the adolescent who have limited access to what we call friendly reproductive health services. So it's also an issue. And you have mentioned the fact that when they go to the they fear, they think about some stigma when they go to the pharmacy to buy some product, some contraceptive product, for example. And in terms of like way to go, so I will call for a redefining of concept to centering to in lived reality and supporting local innovation and agency. I think we need to rethink the very language and assumption we use. For example, when people talk about unmet need, we have to interrogate that different concept, the access, empowerment, to see if the definition we give given by public health is the same than the one experienced by communities. So I think we really need to do that, to have that step first. And because if a woman use a contraceptive but feel unheard, unsafe, or unsupported, she's not satisfied. She's unsatisfied. So we cannot just say because she access, she's satisfied. She's not satisfied. She access, but the product is not for her, is not fine for her. So she's not satisfied. And also adolescents, because adolescent sexual and reproductive health is something really, it's a very big problem. I think the target adolescent itself is problematic. Even if malaria, we now seen that they are problematic too. So we really need to address that that target has something specific in each country, not just having a polish a policy for all the LMIs adolescents or something like that, but having something really contextual, addressing poverty, education gap, and also gender-based violence, through inclusive and cross-sectoral approaches. And yeah, so in terms of yeah, I think I will just stop here. So because otherwise I will pass my time. I don't know if, yeah.
Thank you so much, Mariam.
Cool.
I think you touch a very important point when you highlight this kind of social stigma that young people, not only young people, even though it's mostly linked to young people, especially girls, and I think this is a very important issue they face when attempting, for example, to access contraceptive product. And the example you mentioned is very telling. When buying, for example, this product often invites judgment, and it reinforces also the silence and misinformation around reproductive health. So and the other issue you touch upon is the language we use.
Yep, the concept.
but also the policies that are being provided. And I think there's no one size fit all policy. And policy should be context dependent, but also the language we use can also sometimes spark stigma because it doesn't necessarily take into account social realities. That's why I want to ask a question, and this is also a question I'm asking to Gina. How do social norms and community expectations in places you are talking about, whether Kurube or Kamakwi, I think, how do those norms and expectations shape teenagers or women's understanding of sexuality and their ability to make informed choices? And this is a core question. I just want to have your take on this before opening, of course, the door to questions and interventions, of course.
Yeah, so I will say there was a difference between the rural communities and the urban communities. So when I asked the girls in the girls and boys in the rural communities about, if they have a boyfriend, a girlfriend, or anything like that, they were like, when we got to that part of the interview, they actually started whispering. So I think in the rural areas, it's more like them having relationships, it's, more secretive versus in the urban areas, sex is also seen as a means of survival. So it's not as, covered. It's not as like hidden. There are like signboards in Sierra Leone talking about safe motherhood, say yes to the abortion bill. So I guess it's a difference in location. The urban communities, and that's really what I was looking for in this study. Like when I started designing it, is that seeing the differences between urban and rural communities, because overall in Sierra Leone, the literature shows that, there's very high maternal mortality and, low contraceptive use rates. And so I was curious to know what it was like, the differences between rural and urban, if this is said about like the whole country, as a whole. I hope that answers the question.
Thank you so much. Mariam?
Yeah. For me, from my field work, what I have two points I have noticed. I can, where I had one community which kind of semi-rural and another one a rural one, semi-urban, pardon, sorry, and a rural one, and the semi-urban was the Mandinka. Mandinka community, and the rural one was the Wolof community. It's the Salem who are going to the Casamas for l'agriculture.
Agriculture, of course.
Yeah, for the agriculture. So it's the two communities where I did my work. And what I have noticed is that at the Wolof communities, which is rural there, decision about contraception or everything related to health, woman health, is taken by the husband, by men, by elder people, while in the Maninka communities in Jarumbe, there the decision is taken by the woman. And the rationale they gave is that because there, what I have noticed is that women are the provider. They are the one who go work and sell things and bring the money, while men are settling under the Bantamba, these big trees.
The big three, the public three.
So their rationale was, I'm the one who bring the money, so I will be the one who take the decision. So I won't ask my husband or anyone else about my health. So that's what the first thing I have noticed there. And the second thing, also this one I only noticed it in the Maninka area. It's again related to economic reasons. So the mothers of children or adolescents who have undesired pregnancy. How do you say it? Is it undesirable? Les grosses indésirées?
It's an undesired pregnancy. Pregnancy.
Okay, yeah. The mother for who their children, their daughter have an undesired pregnancy, they talk about the risk, the economic risk for them, because they are like, okay, if my daughter had a child, I will be the one who take care of this child. So I have to work more to take care of this child. So I don't want my daughter to be pregnant. So I will go look or seek for contraceptive method for her. So yeah, it's the 2 point I have here in Sergio. I don't know if it's answer to your question.
Yes, good. Thank you. Thank you so much. So we have Raphael is asking a question. Raphael, should I let you ask your question, or do you want me to read?
Sure. Well, I guess the major question is, can you? Wait, give me a second.
Well, I think Raphael has some issue with connection.
Can you hear me, or is there a lot of background? Hello.
Raphael, can you go ahead?
Yes. Can you hear me?
We can hear you very well, loud and clear.
Okay. Okay. I didn't know there was a lot of background. But yes, I mean, first of all, thank you for the presentation.
Well, I think there is some issue with the quality of your voice. Okay, I can read the question.
Okay, is it better now?
Yes, it's better.
Okay, perfect. So first of all, thank you so much for the presentation. I really enjoyed this, especially as someone who doesn't know a lot about reproductive health and sexual health in African countries. So I appreciated that. And I really appreciated the first three findings that you shared with us. I was curious if you also looked at the role of factors like socioeconomic status, religion, family structure, for example, polygamy and monogamy, or whether or not there were both parents in the home, on these children's willingness to learn about or talk about reproductive health as well.
Yeah, so that's a really good question. What I have seen so far is actually it's pretty like equal when it comes to students who are Christian and Muslim. There is actually no differences in terms of wanting to be on contraceptives. I did notice though, for those who were Muslim, they were more like, they did say that, oh, my parents don't know I'm using, this certain type of contraceptive. It's just my boyfriend and I know that we're using this. Versus I notice in the Christian households, they say that, they're more open to talk about it. Like, yeah, I have, the implant and I like it. As in terms of family structure, another thing I did notice, some individuals are raised by their grandparents. So those that are raised by their grandparents, almost all of them were on a certain type of contraceptive. And their rationale was that, oh, my grandma said that, she can't raise any more kids. Like, she can't do that anymore. She's too old. So those were some things that I did find, within the semi-structured interviews.
Very interesting. And I imagine probably some similarities with sort of thing in the US as well. Yeah, thank you so much.
Yeah.
Thank you so much, Raphael. Well, I don't know if you guys, other people have questions or comment.
Hi, I'm PD with Meg. Not a question, but I just wanted to say thank you both for this presentation. It was especially insightful, I think, for Meg and I. We are doing our Fulbright work in Mtwapa, Kenya. It's a city known for sex tourism, child prostitution, and we see a lot of the issues that you guys talked about here. So it's really interesting to hear about your research. So thank you both.
I can't resist the temptation of asking another question. I'm kind of curious to know if there is any traditional contraception method or ways of talking about everything related to undesired pregnancy or other techniques that are locally grounded that people use, that are not necessarily modern contraceptive ways. I don't know if you've encountered such practices or approaches.
Yeah, so two things to that. The first one is that breastfeeding. A lot of them talked about breastfeeding, the teenagers who were already parents, because some of the teenagers had like up to 2 children already when we were doing the interview. So they did talk about breastfeeding. Some also talked about not being on anything. They said that when they left the hospital, they were not talked to about any type of contraceptives. And the other point I wanted to make to that is, as another barrier that I didn't mention was that I had just gone to, a pharmacy, not near these communities, but just in Freetown. And the owner of the pharmacy was Muslim. So I was just asking if, she had a certain type of contraceptive just to see, what they're selling and, tried to compare it like to see if any of these options that I'm even talking about with the students are accessible. And she said that it's against her religion to sell contraceptive options. She was like, it's against my religion. I'm not selling any type of contraceptives here. And it's not good for people. So, I don't sell it here, which just made me think like, okay, sure, I respect, it's against your religion and everything like that. But then it's like, okay, for someone who might need it immediately or like maybe an emergency contraceptive pill, they can't go there. So that was the only pharmacy I encountered like that, but I don't know how many more are also out there, which also serves as a barrier because even if they have the money and the way to get there, then they're not being able to buy, these things.
Interesting.
Yeah, if I may come. I also have noticed also in my field, some, let's call it traditional, like methods. The first one is related to the like breastfeeding because it's something cultural. People used to, I don't know if that it's in your context or no, but here in some communities, what people used to do is once you have a baby, you get back in your parents' home and you stay there for a number of months. So during this period, you don't have contact with your husband. I mean, yeah, you don't sleep together, for example. So it's a kind people do, like when I ask to people about traditional or natural method, they mention that one. And also, I also had an historical approach on when I was like collecting my data. And I asked two people, in the past, do you had some other type of contraceptive method, some other type of contraceptive method? And they were like, well, the way they organize the space in the household is that, the men in the Mandinka like community. Men have are the one who have their rooms. When you just enter in the house, you have the first room are for men. And then when you go deep, you have the rooms, the woman's like place, which is around the kitchen. And if you want to go to the like woman place, you have first to see men's and before going there. And in a term of, and people talk about it in term of like contraceptive method, because they would like, okay, when you are a woman and you give birth, also you have to stay in the woman areas for a number of months before like being able to join your husband in his room. And yeah, this was the two like methods I had who came in my mind. So yeah.
Thank you, sister. Fascinating. I don't know if you guys have other questions. I think we have maybe 7 minutes left, but we may not hold you until then, but you know. Aline?
Yes, Dr. Bodian. I mean, for me, I would like to thank everybody. Gina, because it's something that we discussed for a couple months. Thank you very much for this very interesting presentation. And Dr. Jallo, and as well Dr. Bodian, and Meg and Raphael for taking the time to be here today and making this seminar happen. Thank you very much. Dr. Bodian, if there are no other questions, I think we can just maybe wrap up the session.
Well, I think that I have nothing to add except maybe joining you in thanking all the presenters, Gina and Mariam for accepting to join us. I know that your schedule is very tight, but you accepted to make room to be able to attend this meeting. I really appreciate it and really thank you very much. And thank you all, and I hope we'll see you. I know that some of you are wrapping up. But we'll be more than happy to have you in other sessions. I think this is the last session, Alina.
Yes, for the enrichment seminar.
Yeah, for the enrichment seminar. So, and it's been a pleasure and really a great pleasure to have you with us throughout the year. And wishing you the best for the rest of your stay in your host countries. And hopefully we'll keep in touch. Thank you so much.
Gina has a question, I think.
Yes.
Oh yeah, this is an unrelated question. I just wanted to know when, I guess the other Fulbrighters, like when does your grant end? Like when will you be going home? So
I'm sorry, Gina, what was the question? You wanted to know when would other Fulbrighters finish the grant?
Yeah. I was just asking like when the others will be returning, like,
It depends. It depends.
I didn't know for the other Fulbrighters.
Not everybody has the same date, the same ending date for the program.
Yeah. Raphael said that he's finishing in October 7th. So
yeah, and for us in Kenya, we started in January and we finish in October. So in the last couple months. When did you start, Gina?
So I started in December, but I will be leaving to go back home next month. Yeah.
Okay.
Yeah,
Nice.
coming up soon.
Yeah. Awesome.
Well, you've like packed in really great work. So it was really, really cool to hear about your study. Thanks for sharing.
Well, thanks so much.
Yeah. Thank you all. Thanks.
Thank you. Thank you, everyone.
Thank you, guys. See you. Have a great
Merci,
weekend.
Mariam. Merci d'être venu.
Thank you.
Allô?
Oui, Aline.
Wow.
Tu peux arrêter l'enregistrement?
Wow, attends. Mais comment je fais pour... Attends.
Normalement, si tu cliques, ça va venir.
Ouais, mais qui veut là, disons, icône pour arrêter l'enregistrement?
Tout à fait en haut.
Tout à fait en haut. Wait, I'm seeing a recording, but I don't know what you...
En haut à droite, normalement.
Yeah, I'm seeing it, but
Or you can't stop it. Écoute, on se parle sur WhatsApp alors.
Okay. Let me call you there.